Good afternoon, everybody, and thank you all for your attendance. My name is Dr. Brian Lepow. I'm a podiatrist practicing in Houston, Texas, and my co-moderator here is Dr. Megan Oltmann from University Hospitals. Today we'll be covering fundamentals of wound care, part of the peripheral track, so talking all things wound care, predominantly for the lower extremity. Thank you to the distinguished panel that we have set up here today, and thank you to the speakers. Appreciate your time today, and we look forward to listening to what everybody has to say today. We'll start with our first speaker today, and that's Dr. Megan Oltmann. She will be speaking about non-healing arterial wounds. Thank you, Megan.
Hi, everyone. All right, so my first case is a complex PAD patient, and she's got bilateral ulcerations to the tips of her digits. So I have no disclosures for this talk. So this patient comes in. She's a 63-year-old female. She's, again, has non-healing arterial wounds to the tips of her digits. And she's coming in for a second opinion. She is seeing interventional cardiology to see if there is anything they can do to open any vessels up. So she was sent to me to start working on the wound care aspect of it. Pertinent medical history, patient is 48-year insulin-dependent diabetic. She is status post-kidney transplant, known peripheral vascular disease, coronary artery disease. Social history is she has never been a smoker. She is married with 2 children, and she lives on a farm. So this is initial presentation with interventional cardiology. So we can see right side and left side. She's got some non-healing ulcerations. Going through the records, these were present since around Christmas time that year. So they were present for about 4 months before we saw the patient. At this time, she was using betadine just to keep them clean and dry and uninfected. So we've got PVRs, ABIs, TBIs. Patient has a TBI on this right side of 0.18. These are called off of the tracings that she's got moderate disease on this right side. Non-compressible vessels, though, as we can see. So she goes in for an angiogram on the right side. I believe her operator is actually in the room here with us. Dr. Hamad over there. So he goes in, finds that she's got significant CFA disease, no disease to the TP trunk, but she does have a chronic total occlusion to the AT, and severe diffuse PT disease. Nothing on the peroneal. So this is again in April. Clinical imaging, May. We go on new studies in May of that year. We're looking around the same 0.13 for that TBI. Left side is 0.27 at this point in time. So I should say that during this whole period of time too, this patient is in a lot of pain. She's in tons of pain, wrist pain, every step, everything she's doing, she's in pain. She wants to dangle her legs all the time because of the pain that she's feeling. She is a very, very compliant patient, though. You tell her to elevate, she does exactly what you tell her, despite how much pain she's in. So continuing along this course, Dr. Hamad took her in for another angiogram on this left side. She's also got some severe disease on this side, ATPT. She's got significant disease. So clinical challenge comes, the first one comes in June of that year. She's got increased pain and modeling to the digits 1 through 3 on that right side. So, I pick up the phone in clinic and I give Dr. Hamad a call, and he gets her in for an angio very quickly on that right side. So in there, again, occlusion at the ankle. PT was occluded proximally at this point in time, and then there was a dissection of the plantar artery. So again, this is all right side, so I do want to point out that this case, I am focusing mostly on the right side, despite it being right and left. So again, she's got some new ABIs, TBIs, She's up to a 0.29 here, so we're getting somewhere. We've got a little bit more flow. Nothing else has been done on this left side, and she's at a 0.57 at this point in time. Not sure why it's increasing, but she's doing a little better on that left side at that point. All right, the next challenge comes when this patient has a mechanical fall. She suffered an epidural hematoma, and she's got several thoracic compression fractures. At this outside hospital where she was taken to from her home, they did discontinue her aspirin and Plavix, obviously due to the epidermal hematoma. She's in a back brace for 3 months at this point in time. She cannot lay flat. So she cannot go back in for any procedures. If we need an angio, whatever we need done, she can't go back on for at this point. Pain is worsening bilaterally. At this point in time, we've got her in pain management. She's really, really struggling at this point in time. And especially now, we're adding the pain not only from the lower extremities, but we're adding the pain from her back. So life is pretty complicated. She does, however, have a very, very supportive spouse who is at every appointment with her. They're retired. Again, they own a farm. Very supportive kids that will come in if husband is not able to. So she really does have a good support system. Also along this time with the support system, the odor is worsening. So we were trying anything possible to diminish the odor because they were having a hard time living with this. On 10/3 of last year, she did have a consultation for a DVA. And again, they had to wait for 3 months because she is in a brace now. So we're just trying to keep these limbs from getting infected and keeping them attached to her body. So again, on this consultation, she had new studies done, and we are, go back. Sorry. So we are now down to basically a flat line on this right side. Left side, we're at 0.17 for the TBIs. So again, patient's in significant amount of pain. So we wait the 3 months. Again, these 3 months, I'm just trying to keep these feet attached to this patient. Even if she needs surgery and we've got, a raging infection, we're gonna have issues going into the operating room because of the back brace that the patient has and not being able to lay flat. During this time, we can see that these are worsening. She's now got an exposed tendon up on the second toe on the right side here. We've got 3 digits that now have issues, the tip of this toe. So we can see, a significant deterioration of these areas. And you can see this dependent rhubarb this patient has. So 2 months later, pretty stagnant. We haven't really moved a whole lot, thankfully. But she's not really making, any improvement, but we are at that 3-month mark. So patient is worked up again for a DVA. She actually had the DVA done on the left side. So left side was done. That was completed at the end of January. And to be announced when she's going to have the right side done. However, as we go on, her TBI on this right side is now up to 0.73, and the wounds are healing. So the tip of this digit fell off in February of this year. So her distal phalanx fell off. It auto-amputated itself. Along with this, she was also on a course of IV antibiotics after she had the DVA on the left side due to osteo in the digit on the left side. So the right side has actually come along really well. Again, auto-amputation of this area. And after we knew that she's got some type of blood flow on this side, I did start debriding this on a regular basis and using Meta-Honey to get the resolution of these digits. So here we are. I actually saw her this week. I'm working on her wound on the other side, on the left side, for her DVA side, where we actually only do have a big toe amputation at this point in time. She's doing really, really remarkable on that side as well. But I thought this was an interesting case just because we know, looking at those angiograms, that she didn't have good blood flow. So we've got angiogenesis somehow because this patient is doing remarkable. These feet are healed up. There's no issues. I can say on clinical exam, she does have a very cold limb on that right side. It's much, much cooler compared to the right side. But overall, she's doing really well. Again, she's just healing up the last bit of a big toe amputation with her DVA on the other side. Actually, I saw her this week, and she was so excited. She rode her horse for the first time in about 2.5 years this past week. So overall, doing really well. Through the course of the wound healing on this patient, I use things like betadine, just keeping things dry and stable, can help a little bit with the odor. And then we did use Santal at one point in time, so that's an enzymatic debrider. It wasn't really coming along very well, so I did switch to MediHoney, and that seemed to be working a little better. That's an autolytic debrider. Overall, though, patient did well. I just kept her in sandals or surgical shoes. We never really had any edema on this patient for either side, so I never had any compression on her. Obviously, we wouldn't want compression, as her vascular studies are, terrible. But nothing for edema control. Again, infection at one point, she was on a course of IV antibiotics, and then just simple dressing such as Santal, MediHoney, and betadine. All right, any questions? All right.
Awesome. Great job, Dr. Oltmann. Thank you very much for that. We will move on. Announce the next speaker.
All right, so our next speaker is my esteemed colleague, Dr. Teresa Carman from University Hospitals.
All right, good afternoon, and thank you for the chance to speak today. I have 2 cases of non-healing venous ulcers. I have nothing to disclose for these. So the first case is a 67-year-old gentleman, and I've seen him for a while now, but he comes back in with yet a recurrent ulcer. So ulcer recidivism is a significant problem in the world of venous disease. He's still working in the manufacturing industry. He's on his feet all day. He has relatively poor compliance with his compression after ulcer healing. His first ulcer was before I met him in 2013. His first recurrence is when I met him in 2017. It usually takes several months to heal. His most recent recurrence was in 2023 and 2024, and now again in 2025. So his pertinent history is after he presented to UH in 2017, he underwent GSV ablation in 2019. He had reflux. The vein was relatively small. We had a fair degree of complication trying to get his insurance to agree to the ablation, but we finally did, and he was able to heal relatively quickly. He remained healed until 2023. Can you give me a little help? There we go. So this is what he looks like in 2024 when he comes back. We finally get him healed a few months later, just using standard wound care and really good compression. But then he comes back in a few months later, and he again has this ulcer recidivism. It's really always in the same area. It's right around the left malleolus and or sometimes a little bit higher up in the gator area. So I went ahead and I got a repeat venous imaging, venous insufficiency scan, because we had closed his GSV from roughly the knee to the groin when in 2019. And his most recent imaging, he does have reflux in the calf great saphenous vein. And then he has several perforators. So you'll see that the veins are relatively small, particularly the perforators, 2.8 millimeters and 2.3 millimeters, and that becomes a little bit significant a little bit later on, although the reflux time is fairly substantial in all of these vessels. So that's a little bit of a problem. So here's our clinical challenge that we face. ulcer recidivism is common. So even from the EVRA trial, which is a trial that looked at early venous closure versus delayed venous closure and ulcer healing, recurrence rates at 4 years are about 35% if we close those veins early and 40% if they close late. So I almost always tell my ulcer patients, we will see you again. There's a really good chance because these are going to come back. We know that if we can maintain good compression in these individuals, that we decrease those rates of recidivism. But you can see on the right-hand side of the slide, recurrence rates at 5 years, even with maintaining 30 to 40 millimeters mercury of compression, about 30%. And if we can't maintain that degree of compression, we're up around 60%. So we have issues in maintaining, trying to keep these patients healed, there's no doubt. So what are our ongoing clinical challenges? Venous disease is progressive over time. So just because we've done a single ablation, if I have these issues, I will go back and look again and say, what else is there or what may have progressed over time? We know from several of the epidemiologic trials that have been done is that if you look over time, these patients are going to have more disease. He has relatively small perforators, so the definition of a pathologic perforator is greater than 3.5 millimeters and greater than 500 milliseconds of reflux. So he's got reflux, but I'm not clear what we're going to do given that the perforators are 2.8 millimeters and 2.3 millimeters. For him, he's still working, and we've had issues with compression reimbursement. So if a patient is in Medicare, we can get those compression reimbursed if they have an active ulcer that's being actively debrided. Because he's still working, his insurance doesn't cover this. And I've had issues with him wanting to pay for it. Once I do get him to pay for it and get it into his hands, I've had issues of compliance. So I'll put him in to a 30 to 40 millimeter mercury layered compression garment, and he comes back in just using a 20 to 30 component. And so we know we're going to sort of be set up for some ulcer recidivism. And I always talk to these patients about the concern for the natural history of ulcer recurrence. So I don't necessarily have a clinical resolution to him yet. We're still trying to get him healed. We're about 4 months into this, and he's getting better again with compression, but it'd certainly be nice to be able to get a longer-term fix, and I'm hoping that we can get there. The next case I want to present to you is a 97-year-old lady who presents with a left lateral calf ulcer. It's very painful. You can see on the image there, it's got a mixed fibrogranular base. It's been non-healing for several months, and the primary care doctor has given her antibiotics without any real improvement. She doesn't have rest pain. She doesn't have distal toe ulcers. Her Doppler signals are monophasic. Other than the fact that she's 97, she's fairly healthy. She has a history of hypertension. She does use a wheelchair for her ambulation. She's very sedentary. So you can see on these images, her PVR and her ABI, she is non-compressible, but she has monophasic waveforms. She has fairly moderate disease, and her TBI is decreased. And you can see on the second image there, after several months of really trying pretty good wound care and putting her in some gentle compression, we haven't made much headway, and she does have a lot of pain. So we do have a guideline in these individuals. If I can't feel pulses, I'll get an ABI. I'll make sure I know where I'm at. I don't worry about applying too much compression until the ABI gets fairly severe, but we are very careful in our office. So this is a mixed arterial and venous ulcer, right? So we have the classic findings of venous disease. She's got hemosiderin staining. She's got extensive lipodermatosclerosis. She's got edema that we were able to get on top of, but she does have fairly modest disease, and she has those typical features that you would expect for patients with atherosclerosis. She's 97 years old. She has underlying hypertension. She doesn't really have other demonstrable vascular disease per se, no cardiac disease, no history of carotid disease. So what's our challenge here? In patients with mixed arterial and venous ulcers, those that have had very little improvement with compression and good wound healing, we have to step back and say, how are we going to address this? What are we going to take care of first? And so I'd actually be interested to hear what the panel thinks right? Do we kind of continue with our current management? I haven't made much headway in about 3 months. Should we biopsy her? This looks like a fairly standard ulcer. I didn't have any concerns at all that this was malignant or anything else. Do we proceed with additional management of her venous disease, or should we just go to arteriogram and intervention? What are your thoughts?
I usually would go for the arterial management first in this case.
Anybody else?
I agree. Generally, if they have a mixed disease like this, I treat the arteries first so that we can do maximal compression for them.
I would also agree. I think one other thing to consider is the age of the patient and what's being done from the nutritional standpoint to ensure healing. I think that's something to consider as well.
Yeah. So, interestingly enough, she lives with her daughter, and her daughter is incredibly devoted. She's done extremely well taking care of her mom, and so I didn't have too many concerns. But I do agree, most of my elderly patients, nutrition is a huge part of this. So, so we did go on and do some arterial imaging, and I'll go through that in a minute. So many people think that we can't compress mixed arterial venous ulcers very well, and certainly it can be challenging, but as long as you have a reasonable ABI, you can usually provide gentle compression. Again, like I said this morning, this is not compression that I would put in the hands of a home healthcare nurse who may not have quite the same skill level as the nurses in my office, but I do trust my nurses in my office to apply compression to many of these patients as long as the ABI is greater than 0.5. And we see them frequently, and we make sure we're not having any issues. You've got to get rid of the edema, because that's the only way you're going to deliver the appropriate oxygen nutrients to the base of the wound. And you can see these are just a couple of trials that looked at how well we can heal wounds in these malperfused ulcers. Group 1 in this case is a normal perfusion, patients with normal perfusion. Group 2 has sort of mild impairment. You can see the ABI there is 0.57 to 0.85. And then group 3, a more severe impairment in their perfusion with an ABI of 0.31 to 0.5. So really, once we start getting down to that 0.5 range, these ulcers are not going to heal, and we're going to have to do something to help these patients. This is some of the best studies that I can show you that compressing these patients works okay. Now, this is a relatively small study, 25 patients with fairly modest ABIs, a mean ABI of 0.57. But you can see that even with 20 to 30 or 30 to 40 millimeters of mercury compression, we get the benefits that we think we should get with improvement in injection fraction without affecting TCPO2 at the level of the foot or toe pressures, absolute toe pressures. So again, I think in the right hands, you can generally compress these patients and have a confidence that you're going to be okay. You just have to keep an eye on them. So I did send her to Dr. Shishabor, and one of the big things that I always do in this situation is I have a conversation and I tell them, this is not a CLTI patient. I don't need inline flow. I just need a little more help. Because I think it matters what your expectation is, and it matters how much work needs to get done once you go in and get the imaging. I did not do an advanced CTA for this. We sent her directly to angiography. She underwent ultimately SFA recanalization, drug-coated balloon, angioplasty, and then there were some small lesions, proximal and distal, and they did atherectomy. Unfortunately, it was complicated by a little bit of a PT embolization, and they did a thromboembolectomy. She did quite well. And then you can see I've got improvement now on the left side of my waveforms. Obviously, she's calcified, so all I have are waveforms to demonstrate this. But then we started to get pretty good ulcer healing. And by later that year, she was indeed healed. That was, when was that? 2019, I guess. I saw her last week. She's 105. She looks great. Her daughter's taking wonderful care of her. They summer in Michigan and they winter in Cleveland, and we've had no ulcer recidivism. We keep her in compression. She's doing fine. So one of the things that I think is important to appreciate this, and the reason I went for the arterial disease first over the venous disease, is this is also a lateral ulcer. So in all likelihood, if I had venous disease or severe venous disease, this would be a small saphenous or something like that. And I felt like getting the arterial perfusion would be more important than trying to address her venous disease. So just some key take-home when you have these patients with venous disease. Compression, good ulcer management, and managing the underlying pathology is what's really important. Those are our keys that we have to focus on. Ulcer recidivism is very common, particularly in the venous disease patients, and I think you have to educate them really well about what the expectations are as far as recurrence. Mixed venous and arterial disease really requires a comprehensive management plan, and in many of these patients, we may go for the venous disease first. But in this lady, I felt like the arterial disease was sort of the low-hanging fruit and thought we could get where we needed to be. And again, communicate those considerations to your interventionalist so you can both be on the same page and you know where you're headed with things. Be happy to take any questions.
I had one question for your first patient who had the ulcer recurrence. I noticed that he had deep venous reflux. Now, we don't have too many treatment options currently for that, but I know that NVivo is coming out with the valve in the common femoral, hopefully later this year. And do you think that has a role to play in this kind of a patient?
Yeah, so his deep reflux is not all that significant. I don't recall how long it was, but I don't think I'm as worried about that. What I have not done and might be worth doing on him is looking up into his pelvis and seeing if there's anything there that contributes. I really have been focused more on, you know, what really is going on distally with him. He healed very quickly, and he stayed healed for about, whatever that was, 3 years, 4 years, after we got his venous work done the first time. But we've had now annual recurrences, and so I do think we've got some work to do to figure out where all that venous hypertension is coming from.
So one of the questions I have in venous disease and venous ulcer, how do you differentiate between deep venous versus heart versus superficial venous? So how do you have an algorithm to figure that out, you know?
Yeah, so those are good questions. So he doesn't have any underlying cardiac disease. This is unilateral. His right leg is completely normal. Never had an ulcer, it's not in compression. This has all been unilateral disease. I guess that's maybe where going up and looking at his pelvis might be a little bit more important. So usually if I'm looking at, you know, do I have to consider cardiac concerns and things like that? If I have bilateral disease, you know, bilateral changes, bilateral ulceration, definitely I start at the top because I think you have to exclude whether there's a coronary component or there's a central component, or not coronary, but a cardiac component or a central component that may be contributing. When it's unilateral disease, we do tend to focus more on the quadrant, right? So we'll start with just the venous insufficiency scan. We may need to go up and look into the pelvis if there's significant reflux. His is really isolated to that common femoral vein. And I think, if I'm not mistaken, because I think the reason now that I haven't done that too, now that I think about it, his waveforms are okay. And I know that that's not perfect, but if I don't have concerns about continuous waveforms or something where the waveforms look blunted or the augmentations look blunted, I tend not to go there initially.
Especially because it's a left leg, that might be a consideration because he may have underlying May-Turner.
Correct. Thank you.
Great job. Thank you very much.
Okay, up next we have Dr. Ramanan, and she's going to be speaking on her perspective as a vascular surgeon on wound care.
Good afternoon. Thank you for the opportunity to present. I have no disclosures. So I have a few cases. This first one is a 54-year-old female who presented to our clinic with left leg foot wounds. She had a history of aortoiliac occlusion in the past, and she had had bilateral iliac stents placed 1 year prior. Those are her ABIs. So we scheduled her for a left leg angiogram, and based on the CT scan, she basically had left external iliac stenosis, left SFA occlusion, and then what looked like one vessel runoff to the foot. She presented to the pre-op area, and this is what we found. So her foot was obviously erythematous. That area on the plantar aspect of the foot that's white, it was very boggy and very tender, and there was erythema extending up all the way to the mid-calf. And this is a very different exam from what it was in clinic. So when I saw her, 2 questions came to my mind. First, she has an obvious infection, and I thought it would need to be drained first before we did an angiogram. And second, is this foot salvageable? So I called my podiatry colleagues to evaluate her. So since we have a few colleagues here, what would you do for this?
I mean, I'd be curious to see what things look like on an x-ray. That plantar wound does look suspicious. And I certainly would want to temporize that prior to any revascularization and or have that kind of going on hand in hand to ensure that, things, we always kind of call it pouring gas on the fire once they get revascularized. So, I think additional imaging is necessary to see if there's any underlying osteomyelitis. Is there any deeper soft tissue infections, such as a necrotizing infection, before proceeding with any kind of revascularization?
So we totally agreed with that, and so we canceled our angiogram. She got admitted. She got an X-ray of her foot and an MRI. So the MRI did show some underlying osteomyelitis. There was no gas in the soft tissue. So she then, so these are the challenges, obviously, a foot infection with osteomyelitis. And then after that was addressed, then we would need to revascularize her leg to aid with healing of the foot wounds. So she first underwent a IND of her foot, and then a biopsy of the first and the third metatarsals were also done at the same time. And then we took her for an angiogram. We stented her external iliac artery, recanalized her SFA, and she had one vessel runoff via the perineal, which gave pretty good collaterals to her foot. And then her ABI improved significantly, and her toe pressure went up to 69. And then that's how her foot looks now. It's not completely healed, but it's well on its way. My second patient's a 70-year-old female who has left lower extremity wounds and cellulitis. She has multiple comorbidities, including hep C, hypertension, and pancreatitis, in addition to the usual cardiovascular comorbidities. And this is how she presented. So she had gangrene on a couple of toes, an ulcer on the second toe, and she had associated cellulitis. So when we evaluated her with our podiatrist, we got her admitted for IV antibiotics first so that the cellulitis could get better. She got an ABI and pretty significant peripheral artery disease with essentially no flow to her toes. So the challenge is, again, the cellulitis needs to be addressed first. And this was addressed with some antibiotics. Once the cellulitis got better, then our plan was to revascularize the right leg and then have the podiatry team take care of the gangrenous toes. So we did an angiogram, which showed a popliteal short segment occlusion, and that was recanalized, and she had 2 vessel runoff to her foot, following which she underwent amputation of multiple toes. And then on the right is her foot wound, which again is on its way to healing. The third patient is a 76-year-old female who had right lower extremity wounds. She had had a previous stroke and some dementia, and she was living in an assisted living facility, and she was pretty frail appearing. She was able to ambulate at the facility with a walker, but she had a heel wound as well as some gangrenous toes. So these are her ABIs. And her CT scan showed an occlusion of her right common femoral artery, as well as the SFA, and possibly 2 vessel runoff to her foot. So she had multiple challenges. So when we try to see whether a patient is a surgical candidate, first, medically they need to be able to undergo general anesthesia for common femoral endarterectomy, or we have to consider alternate techniques like endovascular procedures. She had to have infection of her groin treated because she had severe intertrigo. She was frail, and so we were trying to decide with family whether she should undergo any procedures and try to save her leg or do an amputation. And then we also had a multidisciplinary involvement with podiatry to figure out if her leg was salvageable. So we decided to proceed with revascularization first, did a common femoral endarterectomy, recanalized her SFA, and put stents. She had 2-vessel runoff to her foot, and that resulted in a significant improvement in her foot perfusion. However, the next day, her foot got really erythematous, and then she got tachycardic and hypotensive, and we were suspecting that she was getting sepsis from her foot infection. So we got podiatry involved, and then they took her for an urgent TMA, after which she did very well. So some of the key learnings for our team was that, so decision-making sequence is very important. If there is an active foot infection, such as an abscess, wet gangrene, or gas, that needs to be treated as a priority. And then revascularization should be done as soon as possible after that to prevent progression of tissue loss after INDs. And then after revascularization, we need to still keep an eye on the foot because that can precipitate an indolent foot infection, which might require urgent care. Thank you, and I'm happy to take any questions.
Great case. I had a couple questions. Maybe you can go, I don't know if you wanted to go back to a couple slides. In a couple, I think it was the second case, there seemed like there were amputations performed. And I was wondering in your center, yes, that case there. I was wondering in your center, do you, number one, is there any role for hyperbarics in these patients? And do you use that? Number two, we're always looking for tissue sparing options. And in my impression, and it's hard without looking at x-rays, but those toes may have been salvageable. So I was just curious kind of what the thought process was, and do you use some of these alternative techniques to kind of help these adjunctive therapies to help healing?
Yeah, so we don't have hyperbaric oxygen available at our center. I work at a county hospital, and that doesn't have the facility. As far as the toe amputation, so the second toe was a partial toe amputation, so they did try to save that toe. However, the fourth and the fifth, I think they had involvement of the metatarsal head based on the MRI, and so that's why there was more extensive amputation done there. So in general, when we involve our podiatrists, they do an X-ray of the foot and an MRI to see what is the extent of involvement of the infection, and based on that, decide on the level of amputation.
I think that's a great question that you asked. When I was looking at this case, it just reminds me of our approach to patient care and long-term outcomes. And when we're considering an amputation of a patient, so for this specifically, having the 2 toes remaining, there's a lot of literature that supports the fact that this is probably going to end up with complications, even within the first 6 months. You obviously did a fantastic job of revascularizing this foot. In my opinion, if we can save the toes, absolutely, but if not, I would probably jump to a transmet amputation from the very beginning. And honestly, too, it's fantastic that they closed, but usually in these patients, I'm going to leave them open, at least for a short period of time. The end-stage renal disease that this patient has, Hep C, these patients have severe microvascular disease typically, so the likelihood of them staying closed for a long period of time is tough. But again, we're all about limb salvage, but sometimes we need to focus on functionality. And the foot right now is not a very functional foot, and it's going to result in further complications and, mess with the great work that you did. So just something to consider.
I think we have to wait and see because she healed right now, but I'm expecting that she will require more interventions in the future. So
Yeah, I think it's a great call out. And I think again, one of the things to consider, certainly we want to save as much as possible, but Dr. Frey is totally right. In these kind of cases, leaving those, we call them like hook 'em signs, here down in Texas, but leaving them with sort of these one or two toes, you're sort of just asking for a problem. These are neuropathic patients, likely for the most part, and all it takes is stubbing that toe, and then that whole cycle starts again. And the more times they come back in, the less chance that they have for potential salvage, and in those cases, a lot of times wind up in BKs. The other thing that's concerning is how far proximal that fifth ray was resected, and once you start getting back to that tendon detachment, you start to develop pretty severe deformities of the foot. So it's always best to try to spare what you can, but at the same time, looking kind of forward for this patient population to determine, well, maybe the TMA would have been the best benefit for them in this instance, and given a more long-term prognosis for better outcomes.
I have a question to the pediatric colleagues. When do you recommend revascularization for these patients? Before amputation, or I'm talking about minor amputation, before amputation or after? Because, I get differing opinions from different pediatrists. When do you recommend that?
It depends if the patient's in the hospital or not. I typically would like them revascularized prior to taking the patient in if we're not dealing, with any infection. I just think you have the best shot at healing. And then we can see on imaging where we have blood flow at. So if we've got a pedal arch, if we've got one vessel runoff, two vessel runoff, what we're looking at, if I've got one vessel runoff, I might be more apt to leave, say, a transmetatarsal open, or it might be an open amputation, or, taking back and closing secondarily. So I think if I can have it done prior, I would prefer that.
Do you worry about patients being on aspirin and Plavix?
I operate on DVA patients, so they're on triple therapy and they bleed everywhere. Not a concern. That's why we have drains.
Yeah, it's only a concern if you're concerned about you're doing a closure and a post-op hematoma forming in there. But I agree with Dr. Oltmann. In these cases, ideally, if we can get intervention prior to us doing the amputation, that's great. If they're presenting with an infection, then we'll drain the infection, we'll do our IND, we'll leave it open, then intervene, and then we'll close. But doing a direct closure after an IND is challenging. So rather have you guys go in.
I totally agree. And, I agree with that infection needs to be treated first, but also the degree of infection matters. Like if it's just cellulitis, like this lady just had cellulitis, I can't get it to move, but just cellulitis sometimes will get better with just antibiotics, and then you can do the revascularization first before the final foot procedure. But if the infection is more extensive, that needs to be taken care of first.
Great job. Thank you.
All right, up next we have my co-moderator, Dr. Brian Lepow from Hope Heart and Vascular.
Awesome. Thank you so much. Thank you all for being here today, and thank you to the CVI family for hosting this. I think this is a great session, and really important part of sort of the gamut of managing peripheral disease is learning how to do proper wound care. My lecture today will be about wound care post-DVA, deep vein arterialization. I have a lot of experience in that world, and so talked a little bit about sort of the processes that go behind managing these patients, because they are quite different than traditional revascularized patients. And then we have a case that I'm going to walk you through. These are my disclosures. And so, look, I think it's important to really start this by saying that multidisciplinary care in this patient population, as we've discussed with this panel, is really critical for the success of these patients. We talk about that probably often when we're doing limb preservation work, but I think I can't express it enough that having that team approach, and even more importantly in this arterialization world, is super important for success for these patients. I work in a multidisciplinary center. I work with a vascular surgeon, my Flomigo, Miguel Montero Baker, who some of you may know, and this is just kind of just showing sort of kind of what a day looks like in our clinics. That's myself, Dr. Montero doing evaluation, and then we have our medical assistant who can help coordinate the care, followed by a nurse practitioner who helps on the vascular side coordinate care, and then more importantly, we have our RVT there, and the RVT really plays an essential role. We try to advocate bringing people out of their sort of uncomfortable, their comfortable environment, bringing them into the space where they're a bit more uncomfortable, and I think a lot of the ultrasound techs kind of just are busy in a dark room scanning patients, but I think when they see see the patient and are part of that greater conversation, then these patients ultimately do well. And this little thing on the left here is just kind of just showing that this is kind of a day in the life of my experience with Dr. Montero. We have endless streams of patients that we go through and talk about, and part of some of the work that we've done at Hope is to sort of better aggregate these. This was probably more early day when we're just using text messages, which is not great for communication. Now we use WhatsApp, which is encrypted, and we also have created a program called Flight Plan, where you can really kind of look at the whole gamut of these patients, and that includes the podiatric component, the vascular component, wound care, any vascular studies that are done, any interventions that are done. So each point in time, there's a little marker that's placed. So it helps to really track them kind of in one setting, which is really cool. We'll advance here, and this is kind of talking about what happens sort of the post-DVA patient. What are the expectations? They're different than the traditional patients. And for those that know the DVA world, understand it, but for some that don't, it's pretty new. The commercialization for deep vein arterialization only happened about 2 years ago, post the landmark study by Inari LymphFlow in the PROMISE-2 study. So, the things to consider in this patient population is, you will see acceleration and healing typically about 4 to 6 weeks. So that's kind of atraditional, right? We don't have just a standard revascularization and then you just go cutting on the foot. We've learned that it takes time for those arterializations to mature. It's a fistula. It's created down on the foot. So it's really important that we kind of take a step back. And I always tell my colleagues that we have to get comfortable with the uncomfortable, right? You're not going to read about these things in the textbook quite yet for podiatry, and so it's hard for the podiatrist out there to say, hey, I got to sit on this gangrenous toe for how many weeks to wait till we do something about it? But this is kind of how things work best with these patients. We have to wait for those arterializations to mature and to show signs of maturation in order for us to proceed. During that time period, the wound may deteriorate, so I think it's important to set proper expectations for these patients. If they come to you with a gangrenous toe, there's a chance it's going to get worse, because in theory what happens is you're creating a bit of a steel phenomenon sometimes to the distal forefoot, and that typically can produce a worsening of a wound site, and or if you're doing an early temporization, things will likely die back. Use caution when performing any surgical debridement that first 4 weeks, as we talked about, and that's more importantly because of the venous hypertension created. And there was really only 2 drivers for early surgical intervention prior to those 4 weeks, and that would include infection and pain. You certainly want to mitigate infection the best way you can, and if patients have severe pain, sometimes there's a need to remove necrotic tissue, but really just doing simple disarticulations at the metatarsal joint, taking off the necrotic toe, and then coming back and reconstructing that foot once they have signs of maturation from the arterialization. And so the ideal wound locations for these candidates, I mean, again, this is still new technology, but for the most part, for these successful cases, and I certainly would advocate this if you're doing this early in your career, if you only had a few of these done, don't focus on those home runs. Look at the ones that are going to be easier cases that you can manage in a proper manner. Make sure that you have your team set up, but really the ideal locations are kind of that distal forefoot. Once you start getting to that midfoot and hindfoot region, it gets a little unknown in terms of what the perfusion is like back there, and if you don't have an arterialization that focuses on the posterior part of the foot, it's going to be really challenging. Most arterializations focus kind of in between that green and yellow area, and so if you get into that and ligate that arterialization site, you ligate your outflow, and there goes your blood flow. And these are things that unfortunately I've learned from experience. As a podiatrist, doing these wet cases is always challenging in one instance, but then when you hit a vessel and it's bleeding all over the place, it's quite scary. And so you just have to be prepared, and really, again, communicating with your interventionalists, your vascular surgeons, your team there is really important to ensure that when you get into the surgical procedure, that you're going to make sure you do the right thing for them. Then avoid amputations that would impede upon the deep venous system of the anatomy, and treat and threaten that pedal loop, and that may disqualify those patients for the TADV procedure in general. So you always want to kind of screen these patients early, make sure that they can get through the long run for this procedure, and more importantly, they have wounds that don't kind of fall back to the midfoot area where you don't really have a lot of choice for proper reconstruction. And we'll jump into a case here. I love this case because this is an older gentleman, an 88-year-old male who comes from a family of physicians. His daughter is one of the chiefs of internal medicine at a large institution in Houston, and his son is an orthopedic surgeon, also part of a big institution down in Houston. And they had taken his dad everywhere to be able to find some help, and really were told the end result is an above-knee amputation. That's all they can offer him. And for an 88-year-old, that's tough, and they're really really only wish for him was to be able to get to Italy, where he has family that he hasn't seen in quite some time. He had a reunion coming up, and they really wanted to make sure they could do that, and knowing that having a limb loss would make that quite challenging. This is pertinent past medical history and the medications here. So this is kind of where things started from the clinical course. This is how this case was presented to us. Now, he had this gangrenous toe for several months, and things kind of began to fester. And one of the things to note is you can see kind of in this upper area here, this little white spot right there, that's always a disconcerting sign. And that's something that really is something that needs to be mitigated. That's usually early signs of infection. And again, with these arterialized patients, you need to wait a good 4 to 6 weeks prior to doing any formal reconstruction on these feet. So you do have to kind of think ahead. And if something doesn't seem right, remember, we talked about 2 drivers for early intervention: pain and infection. And if you don't mitigate those, it's going to be a disaster. And I've been there. And so, when this patient initially presented to us, we discussed options for him, and ultimately they wanted to proceed with the deep vein arterialization, knowing that failure would ultimately lead to an amputation, right? And so they've already been told that. So the idea was, what can we do to create a functional outcome for this patient to be able to, get him a bit more longevity in life? And so here you can kind of see kind of the preoperative assessment. And I initially took the toe off, and I'll show you, but this is kind of showing kind of the angiogram preoperatively, and really no flow. He's got a true desert foot here. You can see the picture on the left. There's no flow really in that distal forefoot here. So there's no way things would heal. And no wonder why this patient was kind of set for above knee amputation. We just didn't have a lot of operators in our area doing arterializations. So because of the concern for infection, I proceeded with the partial first array resection. Left this kind of open, and this was an earlier case. Typically, we don't close these, and you'll see why. They do tend to fail often, closure of these procedures. But as a podiatrist, it's kind of all we really know. You take something off and you close it. It's very traditional for us to leave big open wounds to let them heal by secondary intention. In these arterialized patients, it's kind of what you have to do for the most part to get them to heal right, and they do great. And again, it just kind of limits the take back. We're trying not to create a situation where these patients are kind of a revolving door, and these patients know that they've already been offered a major amputation. So if we can take part of a toe, take the midfoot, TMA, that's a successful outcome, I would say, in most of these patients. So this is kind of immediate post-op here, and that kind of progressed. And this is something that we use to kind of assess our preoperative disease pattern recognition. We know that traditional screening methods, such as ABIs, are really unreliable in this patient population. And really, for the most part, in most of the diabetics who have CKD and other comorbidities, the typical ABIs are not great. So we use what's called pedal acceleration time, or PATs. And this is just kind of a great example of kind of what the process looks like when we do those. Our ultrasound techs are highly skilled to be able to develop these kind of patterns here. And we really look at blood flow to the actual wound itself. So it's not just doing the standard ABI. We're looking at PAT scores right to the wound. And that gives us a good idea when that foot is mature in terms of being able to proceed with the procedure and how that DVA is doing. And so here you see now the patient's been revascularized. My flow amigo, Dr. Montero, did a great job doing an arterialization. You see that nice kind of flow pattern here. And this is kind of an early phase of that DVA. And what happens here is, yes, you get this kind of robust flow, but you see the distal forefoot is pretty much still ischemic. Over time, what we've seen as that arterialization site matures, you get more distal perfusion. And so this is the need to wait. You're kind of forcing blood flow down, and it goes into sort of the dormant or hibernating arteries. And those arteries that may have not been present for 20 years that we're seeing that are waking up. There's a great study that's been done by Roberto Ferrarisi out of Italy, and he has imaged hundreds of these patients over a 2-year time period. And it's amazing to see kind of where these patients were and where they are and how much perfusion happens distally. But this also is a great segue here to show why TMAs work really well in this patient population. You can kind of see where the blood flow essentially kind of ends. And even though getting distal perfusion is important, I think for the most part, a lot of these patients do really well with TMAs. In this case, he didn't need it, but you'll kind of see how we work through here. So you saw we did the initial removal of the toe, partial first array section, and that ultimately failed, diebacked and failed, which kind of was pre-predicted, but now you have a big open wound. This patient here is now, we go for PAT scoring, for those that don't know, it really goes from a class 1 to a class 4. Class 4 being kind of the worst case scenario, an ischemic foot. Class 1 being those patients who are ready for revascularization. So this is about 6 weeks out. Patient is now class 1, and reconstruction can now take place. But we've learned in the past that even if you're doing formal reconstruction, closure is still not great for these big open wounds, especially for these partial first rays. I personally don't have a lot of great success. I don't know what my colleagues feel about them, but I don't love partial first rays. I think that I struggle a lot with those. I don't know if you've had any kind of expedited experience about those, or just better luck with managing those patients. But I struggle, even with hyperbarics and stuff. They tend to fall apart often. And TMA is usually helpful. This case, we were lucky, which I'll show, but he proceeded on and did well, and what we wound up doing is negative pressure. He subsequently developed some osteomyelitis of the second metatarsal, so we had to take the second toe, but ultimately he wound up doing well, and this is just kind of showing kind of how we image these patients throughout their continuum of care in our clinical setting, and this is doing kind of PAT scores. They get scanned every 2 weeks to ensure maturation of the arterialization site. And one of the things to note, that this gentleman's arterialization was occluded at 3 months. That's one of the other things that we see, that even despite occlusion of the arterialization site, these patients still perfuse, and it's called conversion. They kind of convert over, so the arterialization is not even necessary in the long term. So I think that's something to consider. And we use various devices. These are hyperspectral imaging devices to kind of help just put all the pieces of the puzzle together to ensure that we get the best outcome for healing. And this patient went on to do quite well. You can see kind of the wound care trajectory here, and ultimately did great. Didn't need too many other secondary procedures. I think he had the initial temporization followed by just a second toe RAM. Other than that, 2 procedures from a podiatric standpoint, and I think 2 procedures from a vascular standpoint, and this patient went into diabetic foot remission. And here you see here, he's about 2 years out from his arterialization and doing fantastic. And this last picture is really something I love to see. And this is, again, remember I told you at the beginning of this story for this case, this gentleman, all he wanted to do was get on the beach in Italy and spend some time with his family. And here he is. He sent us his pictures, and he's given us the right to show these. But really an awesome picture here showing kind of this guy just living the life in the Italian coast. And really this would not have been made possible if he had a major amputation. So find this to be a great success. He was in this past week, and despite that arterialization being occluded, remains in diabetic foot remission. The key things to consider with these patients, again, once you get to this phase, is making sure that they have proper shoe gear, adequate support. It's, again, it becomes a revolving door with these patients. So the worst thing you could do is just send them on their way. He sees me every 2 months. He's tied in to an orthotist and prosthetist, having good foot care, and that's kind of half the battle in the end of these patients. And so just some concluding thoughts on post-TADV wound care. Wound care provider really should be educated and trained in advanced wound care modalities. There's a lot of nuances that go into this, and if you don't have a lot of experience in wound care, it's not that you can't do it, but I think that these patients are sort of just a subset of general wound care, and you have to be really open to thinking outside the box for these patients. Multidisciplinary care is essential. I can't say it enough. If you're not working in a multidisciplinary care center, don't have a podiatrist, an orthotist, a vascular surgeon, those people, that team around you, it's going to be really challenging. Avoid patients without adequate motivation. Again, there's a lag time, right? There's going to be 3 months or so where not much is getting done post-arterialization. There may be pain, regular visits. They may need surgical debridement to remove any necrotic or infected tissue. So avoid those patients that really don't have the adequate motivation and or social support to really get through the finish line. Patients must be vigilant about reporting any new signs. Every time a patient sees me, I tell them that's their baseline day. Something seems different, I want to know. Email me, call the office, let's hear about it, let's talk about it. Don't wind up in some random ER in your community because your leg will get cut off. We see it all the time. And then lastly, physicians must be able to provide contact information. I don't love giving out a cell phone number. Sometimes they do to a fault. A lot of times providing an email. I think most patients don't abuse it. They just want to know that they have a contact point, and they want to know that they can call somebody if there's a problem. I'd much rather them send me an email, send me a text message, hey, something's up, send me a picture, versus them popping up at some ER randomly in their community and likely winding up losing the leg. So thank you all very much. If you have any questions, we'll entertain them, or if not, we'll chat later. So thank you very much for your time.
All right, thank you so much. I have one question for you. Thoughts on a wound vac? Do you use them on all your post-DVAs, and what's the settings that you use?
I do. I think negative pressure is a really important part, especially if you're doing open wounds. I think after the initial procedure, I usually do just like a wet to dry, Vosh, Stakens, or some sort of agent, but then I'll convert them over negative pressure a few days after, and that's usually at a low pressure setting, anywhere from about 75 to 80, depending on the system. I think we don't go much over that. And what I've seen is when you have higher pressure systems, you get necrosis along the skin borders, and so that just indicates more procedures.
So I have a question, Brian. It's very interesting what you guys are doing in Houston and with the Hope Vascular and Podiatry. Can you please explain how this evolved and what is the financial viability and how we can replicate this?
Sure. without getting too long-winded about it, my colleague and I worked in an academic setting for 6 years together, developed a limb preservation program, and also trained in a place where limb preservation program was part of it. The toe and flow model is kind of how we talk about it back in Arizona under the guidance of Joe Mills and David Armstrong. Subsequently, we were recruited to develop a program at Bala College of Medicine, and the hospital system was great early on, but unfortunately they just started to give up on us and our patients, and it became really challenging to do the things and get the things that we needed to take good care of our patients. And so, Montero kind of looked to me for advice and said, hey, what do you think about going private? And I initially was thinking you're crazy. And then, as I kind of thought about it, and I'm from Houston, grew up there, and I've worked in the city for about 15 years, and outside of Baylor, I was private. So I kind of knew some of the challenges that some of the other centers were facing in developing a limb preservation program, and they couldn't make it happen. So I said, well, why not? And, financial viability and all those things I think are different in the outpatient setting. We have a comprehensive center that has wound care, hyperbarics, we have an OBL, and then we have an educational suite. So, we're a multifaceted group that has various sources of revenue that can get generated in, but it's a different animal. The nice thing about it is that we can pivot easily. We're able to make changes on the fly. We are making a difference. We are profitable. We have 15 staff members and an 8,000 square foot office. We're 2 years in, and we're able to cover overhead and be able to pay ourselves, and I think that's a good thing. And so, I think time will tell what will happen, but I do think there's some great benefits to being in an academic center and having the backing of academics, but we just found it was just, at least in our particular setting, the place where we were at was giving up. And so we didn't have much choice, and we thought, well, maybe looking to do something private could be an interesting model. And so far, it seems to be financially viable. And there's a lot of things as a podiatrist that I have to think differently about in terms of how to generate margins for the practice. But ultimately, it's successful so far. Awesome.
How do you manage foot edema in these patients?
You have to be really careful. Layered compression is not great because you can shut down the circuit. So a lot of times it's elevation of the limb or mild compression with an ACE wrap. As we've done more of these, Montero has probably done 200 plus arterializations over the last 5 years, mix of off-the-shelf and commercial-based ones. So, we've come to learn sort of what works and what doesn't. Edema really doesn't seem to be much of a concern anymore for us in this patient population. They ambulate pretty much immediately post-op, and, we've been working on lower flow volume fistulas, and I think that in turn significantly reduces the peripheral edema. All right, we'll keep moving on, and we'll move on to our next speaker, Dr. Gajanana. We'll be talking about real-world application of Wi-Fi classification. Wi-Fi is near and dear to my heart, as Joe Mills was the creator, so looking forward to hearing about what you have to say about this. Thank you very much.
Good evening. Thank you, Dr. Banerjee, for giving me this opportunity. My name is Deepakraj Gajanana, one of the interventional cardiologists at Cleveland Clinic. I don't have any disclosures. So before we move on or jump to next slide, a quick word about critical limb-threatening ischemia. It's defined as rest pain or tissue loss, that is non-healing ulcer or gangrene lasting for more than 2 weeks, and it has to be related to decreased perfusion to lower extremity. So when we look at the classification or how we stage them, it has gone through different classifications over a span of few decades. The earliest one being the Fontaine and Rutherford classification, which looked at anatomical aspect, and then which is one of the vascular surgeons' favorite. And then when it comes to orthopedic surgeons or podiatry or wound care specialists, they tend to favor the Wagner and University of Texas classification. Now, there is the IDSA classification, which is favored by the infectious disease specialist. So without going into the details, there are several different classifications in these two tables, but one of the challenges was they did not incorporate the wound depth or presence of infection or the severity of wound infection. That's what led to the vascular surgeons to take the initiative and propose this Wi-Fi classification, which stands for wound, ischemia, and foot infection classifications. So it is a more precise classification that kind of takes into account the disease burden. And the advantage of this classification, it also gives you the pursued amputation risk and it helps identify the candidates who may benefit from revascularization. So as I said, it stands for wound, ischemia, and foot infection. So when it comes to wound, it takes into account how deep the wound is and the extent of the wound. So there are grades from 0 to 3, with 0 being no ulcer or no gangrene, and 3 being extensive ulceration or extensive gangrene. Similarly, when it comes to ischemia, the toe pressure greater than 60 is almost normal. It is graded as 0, and the toe pressure less than 30 graded as the severest form, and it is given the grade 3. Now, when it comes to the foot infection, 0 being non-infected and 3 being severe, where it has systemic response or where the patient has sepsis. So there are 3 criteria and 4 grades in each of these criteria. With a permutation combination, it gives close to 64 different combinations. 64 different combinations. And then it applies to all patients with rest pain or tissue loss, and they have to have objective evidence of peripheral arterial disease. So the first table focuses on the risk of amputation at the end of 1 year. So as you see in the top column, we have ischemia graded from 0 to 3, and 3 being the worst. And on the left panel, we have wound classified from 0 to 3, and in the bottom panel, we have the foot infection, presence or absence of foot infection, and the degree of foot infection. So when you look at the clinical stage 4 or clinical stage 4 or the high risk, this is where the patients have deeper wound or presence of deep tissue infection or higher degree of ischemia. So that's the estimated risk of amputation at 1 year. So when you look at these patients who are in stage 3 or stage 4, these are the patients who have a higher risk of amputation if not treated appropriately. Now, the table B gives us an estimate or the likelihood of benefit these patients may derive from revascularization. Now, when these patients have lesser degree of ischemia, they may benefit from early revascularization before the infection or before the ischemia gets out of control. So what are some of the key essentials for arterial wound healing? So there has to be straight line flow from heart to toe or from distal aorta to the pedal artery. Once revascularized, especially in the pedal interventions, we need to have a palpable pulse and avoid post-procedural complications. And as previous speakers have mentioned, there has to be multidisciplinary care or multidisciplinary approach involving infectious disease, podiatry, and vascular surgery. So this is the first case. So this is a 60-year-old male with typical risk factors: hypertension, hyperlipidemia, prior bypass for severe CAD, has had left transmetatarsal amputation. Now he presents with right grade to non-healing ulcer for the past 12 months. He required a grade 2 amputation, and despite that, he presented with non-healing ulcer over the amputation side. So if you were to use the WIFI classification, clearly this patient has what looks like at least a stage, at least a W3, and maybe some infection, which we don't know unless we do additional imaging. And the question is about ischemia. So these were the non-invasive testing. He did have low toe brachial index. On the MRI, there was clearly presence of gas, and same thing that you appreciate on the X-ray. So he underwent amputation, and that was followed by angiogram. As you see on the angiogram, there clearly was occluded anterior tibial that was treated with POBA, and the flow was established into the anterior tibial. So these are the images of healed transmetatarsal amputation site. Now, second case, this is a typical patient, vasculopath, 64-year-old with chronic tobacco use, hypertension, hyperlipidemia, presented with non-healing right foot wound. These were some initial non-invasive testing. So he did have non-compressible vessels. His ankle brachial index was 1.07. This is the CTA, which shows multi-level disease, especially involving right external iliac, common femoral, distal fempop, and anterior tibial. So after discussion with the vascular surgery and podiatry and infectious disease, he underwent hybrid approach. The vascular surgeons took him to the OR, hybrid OR. So he underwent hybrid common femoral artery endarterectomy and right external iliac artery stenting by the vascular surgery. So these are the images post-endarterectomy. Now the problem with this patient was he was non-compliant and he continued to smoke and the ulcer did not heal well. So when there were when we were able to establish some contact with him, we brought him back to the vascular lab, knowing that he did have multi-grade occlusion. So he underwent stage right SFA, popliteal drug-eluting balloon via the right radial axis. So we were able to establish more inline flow, at least into the TP trunk. And then subsequently he was brought again, and the last procedure was obtaining a pedal access so as to reconstitute the anterior tibial. We were able to establish pedal access, and then we were able to reconstitute the AT, and that was the final angiogram. And as I mentioned, this was a patient who was not compliant, and unfortunately we lost him to follow-up. We hope that the arterials are healed. So take-home points. When it comes to arterial ulcer or lower extremity wound, early recognition is pivotal. Always there has to be a drive to determine any underlying ischemia. So when it comes to arterial ulceration or lower extremity wound, multidisciplinary patient-centered approach is quite essential. Early revascularization, maintaining an inline flow from aorta to toe or from distal aorta to toe is quite essential. And plan for repeat revascularization if wound fails to heal. With this, I conclude, and thank you for your time.
Great job. I have a quick plug for those who are interested in I think there's some podiatrists in the community here and in the audience, but there is an app by the SVS to kind of help make this Wi-Fi a little less cumbersome. As somebody who should use it more often and was trained by the godfather of Wi-Fi, you know, when you see that big kind of Delphi scoring system, I think people get really nervous about how do we quantify these. And so there's an app that you can download, and I think it really helps to be able to be more compliant with your Wi-Fi. So if you're thinking about it, or you see this, like, oh man, how am I going to do this? The app does help a lot. And I think what also helps is just, you know, we'll do kind of case conference weekly with our staff, and we'll throw up some cases and just kind of run through them quickly, just to keep everybody fresh. It's not challenging; it just has to be reproducible. But I think it's really a great way to communicate with your multidisciplinary partners about the limb preservation.
That's great. Thank you.
Oh, I think it's just the SVS Wi-Fi. Let's see.
Yeah. So it's available on Apple and on Android system too. Yeah, it is very user friendly. Thank you.
All right, thank you very much. And I think we are rounding off the session with my co-moderator, Dr. Oltmann. She is going to be completing this session, discussing and talking about quantifying wounds, or not. She's doing a no option CLTI status post-DVA. So
Yeah.
thank you, Dr. Oltmann. We look forward to hearing about your lecture.
All right, so yeah, I switched up this lecture. I wasn't here for last year's session. I was actually having a child that weekend. But I listened to it, and it was quantifying wounds, and it's just, I wasn't really driving with it. And kind of in our space right now, especially in the podiatric world, you know, along with Dr. Lepow, we're really focusing on trying to figure out the best way to heal these wounds, these amputations, and get these patients back to life as quickly as possible. So I did choose another DVA case to present just to generate, you know, some more thoughts. You know, if we can talk about this as a panel and what we can do, you know, and from the audience, I think it would be helpful. So, all right. Anyone from UH here will know this case. I know that Kate and Elena are in the audience, so they are Dr. Shishwar's NPs, and we communicate all the time over our patients. The collaboration in these patients are so important, so we have a lot of constant communication. So no relevant disclosures. All right, so this patient is a 66-year-old male, past medical history of diabetes, CKD3, hypertension, hyperlipidemia, PAD, remote history of right second toe amputation in 2015. Also of note, patient was never a smoker. He was referred for a second opinion for a potential DVA, and on the initial referral, he had 5th-digit gangrene with osteo. So this is actually when they got a hold of the patient in clinic, though. So this is back in 2023. By the time he was presenting, he's got gangrene to the 4th and 5th digit, starting to go up the ray as well. And again, there is some osteo in there. I also want to make note on this case. This is actually my first DVA case. However, I didn't take care of this patient until about midway through this case. This is how I actually came into starting to take care of these patients at university hospitals, and this is also why I formed a relationship with Dr. Lepow up here, because he's kind of the go-to guy with lymph flow and has been very helpful. All right, so we can see initially here's the vascular studies, which of note too, if you look at these, we've got waveforms that look better on the contralateral side than what they actually are. So patient goes in, has a DVA. I don't have the initial angio. So patient had several angios prior to coming to UH. He did have an angio prior to the DVA at university hospitals. However, it wouldn't load. I couldn't get the imaging for it. So this is status post-DVA. So we can see that we've got a nice circuit here. We've got good amount of blood flow at this point in time. So now it's a waiting game. So this DVA again was done at the beginning of October, so 10/9. So as Dr. Lepow had said, it's a waiting game. So we have to have really good conversations with these patients about the waiting game. It's 4 to 6 weeks, 4 to 8 weeks. It's a long time. We're waiting for demarcation of these tissues to see when we can actually take them into the operating room. And I think actually Dr. Lepow is the one that also taught me we're gonna look for that halo, that granular halo around these wounds and these tissues that we see. So usually you kind of want to wait for that if we can, if we don't have infection setting in the meantime. So this patient was taken in for an open transmetatarsal amputation about 6 weeks post the DVA. I just want to make note to look at later in the case. So this is a pretty proximal TMA at this point in time, so that is going to affect this case later on. But that was also due to the extensive necrosis on that lateral aspect prior to going into the operating room. So here we are 2.5 weeks past the open TMA, and you can tell this tissue is not looking great in this area. We would expect to see a lot more granulation tissue. There was a wound back on this site, so we would expect to see a lot more red, pink granular tissue. This tissue looks to be dysvascular at this point in time. So the surgeon was contacted, and patient did end up having an occlusion to the DVA. Went in for a successful aspiration thrombectomy of the PTA. We're able to open everything up. So this is the wound, though, at the time of this hospitalization. So significant deterioration. This was over the holidays, so there was a little bit of a lag in time for this patient getting back into the lab to open this site up. So patient was revised again. So revisional TMA went in and took a little bit more bone back. There wasn't a lot of bone to take. Was grafted with a bilayer and a bolster dressing. After the bolster came off, patient did have a wound back again. All right, so this is where I come in. So this site was not healing. The velocities were all good. DVA site was open. There was really no reason that this shouldn't have been healing at this point in time. So my initial contact with this patient was on 4/2 here. So we can see this wound is not looking great. We've got continued exposure, again, of all of the bone that is remaining. So, really good debridement, and within 1 week, so this is just 7 days later, it's significantly improved. Not great, but we are getting some better tissue. However, this area still remains pretty concerning. I was planning for surgery at this visit to get him on the board. Actually, back about a year ago, I was having trouble scheduling cases, so we had to wait to get an operating room after another surgeon's block had dropped. So it was tough to plan this procedure. So in the meantime, the patient goes into septic shock. Foot, again, significantly deteriorates. So any comments from the panel? What do you guys think you would do? I mean, we're really proximal at this point.
Yeah, I mean, these are real challenging because as you think about sort of the anatomy and where that arterialization is, you're kind of getting back to where you can get that arterialization, and so it is tough. The promising thing is if you look at that picture on the right, is you see kind of throughout some of that necrotic tissue, that nice kind of granular tissue there. So that's really a great indicator that maybe even, and I don't know where this case is going, but maybe even despite the arterialization maybe being down, they may have converted in that arterialization site. It may have matured enough to be able to not necessarily worry about it as enough to be able to take that more proximal. So that would be kind of my 2 cents on that.
Okay. So the DVA is up at this point in time. So velocities are okay. It was open back in January. So we're okay at this point in time. But yeah, so we've got a really proximal amputation at this point in time. So that was the decision because we do have the necrosis medially. I've got to get that bone out of there. Inflammatory markers were all high white blood cell count. Obviously, he's in septic shock. So we've got to make a decision here, and it's, again, do I go in and disarticulate and potentially hit the DVA site, and do we make the whole circuit go down? Or, if that happens, we're going on to a BK. I mean, the patient's not going to have any blood flow. So it really was a challenge talking with interventional cardiology. So that's Dr. Shishbor for University Hospital. So we had extensive conversations going back and forth about what would be the safest route. And actually, this is actually when I had called you for the first time.
What is your wound care right now? Is he in it? Is he on negative pressure?
No, not in this point in time. In the hospital here, either Deacons or Vosh went to dry.
Well, I mean, but before this, as he's presenting with this, is between these
Between
episodes?
these visits, this would have just been like a Vosh wet to dry, just because of the infection that I can see with the, with the bones and the central area in here.
And does he have trauma? Or are there other things going on?
No, this patient
is reliable, or is this?
Is it what? Sorry.
Is he reliable, or is
incredibly compliant?
Okay.
Very, very compliant, and has a really great support system. Family is very involved. They'll call if there's issues, but no, we've got a great support system. So as we move on, I ended up taking him back into the operating room. Technically, Liz Frank disarticulation, I did have to take a little bit more off of that medial cuneiform there. And the thing was here is, did the circuit go down? The circuit did not go down. If you look on the previous slides, the circuit is sitting just proximal to that medial area. So I probably had a couple millimeters before I would have hit it. So I did take this patient back in again. I put a bilayer graft on in the operating room, and then he got a wound vac after that. Again, as Dr. Lepow had said, wound vac settings are at 75 for these patients, and wound vac tends to get changed every 3 days or so, with home health care. I'm not sure, have you tried, or has anyone tried the 7-day wound vac, the peel and stick yet from KCI? They do have those, so looking forward to seeing how that works, because if we're using those, we might be able to take home health care out of, helping with our patients. Sometimes they can make things challenging with pulling grafting off. All right, so we continue with this patient. So he still has bone exposure after that silicone layer of that bilayer is taken off. As you can see, we've got bone sticking straight out at us here. I continue to wound vac him, and we start with an allograft. So patient goes on to have 6 allografts, and on 7-2 here, we've got this nice beefy granular tissue here on this open TMA or this open Liz Frank site. I went into labor when this patient was booked for a split thickness skin graft. So actually Dr. Frey up here on the panel took patient in on 7/20 for the split thickness skin graft. It unfortunately didn't all take. So completed closure using, it was a placental allograft, tri-layer allograft. So went on to complete closure. We pulled the wound back after the split thickness area, what we knew what failed and what stayed. So we pulled the wound back at that point. Went on to complete closure. Patient's doing wonderful on the left side at this point in time. He typically ambulates in a UGG slipper. He loves his UGG slippers. I have him in a brace. He also has a toe filler. He hates all of them. He wears his UGG slipper and he gets around just fine. It's nice, hard-soled. However, when I get home, my next challenge is we have to do a TMA on the contralateral side. He just had a DVA over there. Started with a fifth toe ulceration that worked into gangrene. He's had 2 angios on that side. Everything has just necrosed. So we get to start working on the other side when I get home. So, all right. And lastly, I think for myself, learning with these DVA cases as we've been going along is we have to have a lot of patience. I mean, these are really, really challenging cases for us. They're challenging cases for our patients' families. Communication, the collaboration with the team is paramount. If you don't have that collaboration, if you can't pick up the phone and call the other surgeons, the nurse practitioners, it's not going to go well for these patients. I mean, I can't emphasize enough the amount of communicating I do on a daily basis with Kate, with Alina, with Dr. Shishapur about these patients and their continued care. Also to go with that too is, we're taking care of wounds and emphasizing weekly debridements. Weekly debridements are really important for these patients. You get so much of a biofilm that builds up over time. It's in the literature that weekly debridements are much better than biweekly or every 3 weeks. And then just going along with, split thickness skin graft, when you get to that point, these patients can close a lot quicker, get back to life if you can do the split thickness on them. I know sometimes our patients are so sick that we don't always want to put them back under again if we don't have to, so sometimes I do have to rely on allografts in the wound vac for these patients. All right, any questions?
I just have a couple comments, Dr. Oltmann. Great case with a great outcome. With these patients, again, they're a challenge, and it's really kind of thinking outside the box on how to manage it, and you did a good job doing that. There's a couple of photos I wanted to point out. If you go back to kind of where the TMA is, and really, you could probably stop at that next one. You can see on the dorsal surface of the foot, kind of that little red channel there. I think that's something to point out, and that's from the wound vac. And I think those are things that you got to be really careful of. There's certain wound vac systems that have more forgiving tubing versus others, and I think that tubing is not benign, especially in the systems that have that kind of more rigid tubing. And what happens is the tubing gets placed on top of the foot, and the foot gets wrapped, and then you get a compression wound from the wound vac, and that's the last thing you want is to develop another sore. So some of the things that I do as a pearl is I take the sponge and kind of put it up underneath the tubing and then kind of tack that down. So that just helps to ensure that you're not going to cause an additional necrosis. Things to think about really in all these patients. And secondly, I think sometimes the orthotists and prosthetists can get a little carried away with fillers and inserts. And I too have had a very similar experience. I would say a majority of my patients that either have guillotine or open transmets or even traditional transmets hate toe fillers. And I have really started to move away from those. And, I think that in some, maybe they're helpful, but I would say in more than not, the patients do not like them. And what happens is it decreases compliance for proper foot gear. And so a lot of the patients will just kind of stuff the end of their shoe with a sock or tissue paper. And I know it sounds totally archaic and kind of crazy, but they're way more comfortable that way. It just provides a little rigidity at the end of the foot so the shoe doesn't kind of mash up and down. And so, I really have gotten away from using those types of inserts for our patients because I think more of them complain and then they don't want to wear the shoes. So it's kind of my...
Dr. Oltmann, can you go back to a couple of previous pictures? After the DVA, one more. Can you go back a little more? One more? Yeah, I think. So at this point, the DVA is open, right? Yes. How do you routinely do TCOM measurements? Because in our institution, if the TCOM is less than 30, this patient is going for BKA or AKA based on the TCOM.
Yeah, no TCOMs on this, just the velocities.
So do you guys rely on TCOM measurements at all for amputation?
No.
Because there's some powerful data, if it is less than 30,
Yeah.
Amputation is very likely, right?
Yeah, that's definitely in the literature.
I've personally found TCOMs to be really unreliable. I haven't used them at all throughout my clinical practice. I was in a wound care center that used them, but it'd vary on temperature and what was kind of going on with the foot. So I don't want to shoot down the option of using TCOMs because that may be all that you have to your access there. But I have totally moved away from that. And for us, PAT scores, which again I know is sort of a subset of vascular screening, but I find is significantly more reliable for these patients. And Jill Somerset is sort of the lady when it comes to PAT scoring. So there's some great papers out there. She's welcome to train your RVT techs, and she is a force to be reckoned with when it comes to PAT. And it really is sort of changing the game, right? These are techniques and procedures that are really changing the game, changing the landscape for the future of a population of patients, this quintessential CLTI no option patient. And so, while the surgeons have to think differently outside the box, I think the whole team has to think that way. And I think looking at vascular measurements are a really important part of this, and traditional methods just don't really work. And so I think PAT is a really great option, and if you have a team that's open to being trained, I know she'd be happy to do it.
I think that's a pretty interesting question. I don't necessarily use TCOMs for that purpose, but if any of my patients are requiring a transmet amputation, for example, I'll do the TCOM at the transmet site just to determine the reliability of the amputation and its predictive value if it's going to work. So I don't want to take a patient in, do a TMA on a patient when I already know the TCOMs are very poor at that level. So I use it for a level of amputation site to help direct my care. And I'll make sure that then, even if they've got reasonable non-invasive studies beyond the TCOMs, we all know that, ABIs, for example, 30% of ABIs are going to be unreliable. So if I get a TCOM and it's pretty poor, even with normal or reasonable PVRs, I'm still going to send back to Vascular to hopefully at least do an angio and see where we're at.
Have you all had any success using ICG angiography or hyperspectral imaging to image these patients?
I don't have those modalities.
They're great tools. Again, that kind of depends to what you have at your access, but these are all great modalities that, you can do kind of real time. ICG angiography is like a fluorescent dye that you can use intraoperatively. I use them on all my flaps, grafts, TMAs to determine kind of what tissue looks like. It gives you kind of a real time assessment. And a lot of times they're there, you just may not know. They use the ICG for a lot of colorectal procedures, breast reconstruction. So it may not necessarily live in your particular OR, but there's a good chance it's around.
Yeah, I think our system has it. I've had a couple conversations about it.
And you can bill for it. Just kidding.
I have one question for you. So on these DVA patients, you've been taking care of these a lot longer than I have. Have you had any patients that have had successful DVAs that have come back a year, 2 years later, circuits are still open, and they're now requiring an amputation? And if so, are you still leaving them open, or have you tried to close them, or does anything change?
So I don't know that I have seen that many far out, and those that we have seen that are 2 years out really are in diabetic foot remission. What I can tell you is that we have seen some of these patients that are maybe 6 to 8 months out, never really required foot surgery, but at some point had some necrotic tissue. And in those cases, they've already kind of converted over and really have more of kind of like a traditional arterial flow. So those we've been able to close more successfully. I still, I'll stand by my thought process with these patients, and I think for a majority in those that fall in the early phase, open amps are the safest. They're much more predictable, reliable to follow. I know we have some colleagues out there that have had some good experience closing TMAs. I would say for the most part, I've closed mine, and I've learned from experience. I mean, intraoperatively, it's hard. They're bleeding. There's bleeding in the skin edges. You get so excited, and you want to close that flap, and then you get burned by it dying back. And so, I'm trying to limit sort of the revolving door for these patients. And again, these are people that have already been told they're going to lose the limb. And so, if you have to kind of think outside the box a little bit, that's why I don't like to leave one or two toes. And, I think it's important to be more aggressive up front because, again, they were going to lose the leg anyway. So if you can save the foot to keep the leg, great. One other thing that I found really interesting with these open amps is you can ambulate these patients a lot faster. When you close these wounds, in a lot of cases, they have to be non-ambulatory because you're worried about tension on the incision site. And, so I think, and that may linger 3 weeks, 6 weeks, 3 months. Next thing you know, that patient hasn't walked in 4 or 5 months, and it's much more challenging to get them ambulatory after that. I advocate a lot of these patients go to inpatient rehab immediately post-op to ambulate on these feet. Negative pressure helps to bolster that, so you don't really worry about a flap or graft. And, anecdotally, what we've found is that it minimizes pain, minimizes sort of swelling, and more importantly, minimizes some of the biomechanical irregularities that happen with TMAs, kind of that quintessential quantum varus deformity. And I think that when they ambulate early, you get that muscle tendon rebalancing, and so you don't have to necessarily do adjunctive procedures such as TALs or tibialis anterior rerouting to be able to acquire to manage those.
Thank you. Any other questions?
One last question. Do any of you use AI, artificial intelligence, to take pictures of the wound and assess the progress, how the wound heals? Because I know some software out there. So I would like to know that.
I do not. Do you?
I mean, I don't either. If there's something out there, that's amazing. I would say one of my biggest challenges is trying to find a better standardization for measurements and screening. And I know there's some companies out there, it just hasn't become mainstream. And I think that, for us, you want something that's going to integrate with the EMR system. So if you know something, I definitely don't know about that, but that's awesome because I think it's, that's kind of where the future is going for these patients. But yeah, I mean, we use just kind of serial pictures from our phones and upload them to WhatsApp at this point, which is, I don't think, great. I think we can do a better job.
Something that integrates with Epic would be great. Just putting it out there. I have one last question. What is your go-to products in the operating room for these patients for hemostasis? Yeah, I think it's...
Again, these patients bleed a ton. And so not only do they bleed, then they ooze post-operatively. And the worst kind of call you get is at midnight, and, they're bleeding all over the place, and the nurse is freaking out. And so, I've had to kind of really think about what I can use. And there's some products that you can use for coagulant measures, but some of those products leave like kind of a black staining to the skin, and I really despise those because you never know what's good or what's not. And so I've kind of gone to more like the Avitine or Arista-based products. The two products that I find work amazing is Arista, which is a powder, and then there's a sheet form called Ultra Foam. And for me, total game changer. You apply those. Yeah, I mean, you want to coagulate and get some intraoperative, your handle around some of the bleeding for what you can, but outside of that, I will slap one of those products right on top and bolster it, and they do great. It's been a real game changer for me with these patients.
Awesome, thank you. I loved Arista. We just had it pulled, and now we've got the Surgicel powder that makes everything look black.
And the beautiful thing is with these products is they don't stain the skin or stain the surrounding tissue. B, a lot of these products you actually can use underneath these skin substitutes, which in some of them has been a no-no. So that's actually pretty helpful because they absorb quite quickly and they don't act as a barrier.
All right, any other questions?
Questions from the audience? No?
All right.
Oh, somebody back? Okay. Thank you all very much. Appreciate your time today. And if you have any questions, you can reach out to us. But thank you all so much.